Dr. Kirk?
Great, thank you. Are you able to hear me okay?
Yes, we can hear you, but we can't see
Great.
anything right now. Just, there we go.
And are you able to see a single screen, or are we doing the dual screens?
We can see a single screen, but it's small.
It's in presenter mode. I'm not sure. It's the standard presenter mode. I don't think I can do anything about that. So thank you to the organizers. Is it readable?
It's readable, yes, yes. Hopefully you
Okay,
don't have
sorry
small
about that.
font.
It's presenter mode, so I'm not sure. But
Okay.
thanks.
Go ahead.
Good afternoon, good evening to those in Africa, maybe good morning to a few others. Thanks for the opportunity, and thanks for NCI for making sure that liver cancer is recognizable as one of the most important causes of cancer death. But I think I want to share with you some of my thoughts and some of my experiences, and hopefully end for such a dismal diagnosis. I think there's reasons for some optimism in the coming year. So with that, I'll present some data from our ongoing studies, predominantly in Uganda, about how liver cancer presents, the survival, causes of liver cancer, how we can identify and screen those at high risk, with an emphasis on the impact of HIV infection at each of these different factors. And then I'll end up with some other more musings about strategies for interrupting cancer, particularly those of infectious origins, and what we can do to control liver cancer, and perhaps also, as Doan mentioned, leveraging HIV care infrastructure for prevention and control. I'm going to talk to you mainly about our ongoing studies, really built out of a long-term partnership between Johns Hopkins and a variety of different institutions in Uganda. We started the HIV and HCC in Uganda study. It's been 10 years ago. I've been working with colleagues, particularly Dr. Pansano Ochama in Uganda, since around 2006. And we started the HIV and HCC in Uganda, or HTU Consortia, with funding from NCI as part of the U54 program project grants. I'm going to present a little bit of data about our HCC case control study and our screening study among HIV infected persons. First of all, we instituted a case control study recruited from 3 different hospital sites in a couple of different regions, predominantly in the central Kampala region, as well as in the northern region, where we've noticed a much higher chronic HBV prevalence than in other regions of Uganda. We recruited controls from 2 different populations and did a very standardized and extensive and very thorough evaluation, asking lots of questions, a focused clinical exam, a standardized ultrasound exam, as well as a variety of laboratory studies. We originally were going to recruit 600 liver cancer cases and an equal number of controls. We actually ended up, for a couple of reasons, to double that number of controls to have 2 different control groups. We diagnosed liver cancer based on a suspected HCC undergoing an ultrasound with space-occupying lesions and elevated AFP as our diagnostic criteria for the great majority. On a smaller subset, they would actually undergo a liver biopsy that was particularly based on where they were identified, where they were used to doing liver biopsies, and also if the AFP was non-diagnostic. We basically had controls recruited from those specific clinics or the trauma ward who were free of overt liver disease. This is the unfortunate face of liver cancer in Uganda, as well as in much of sub-Saharan Africa. Instead of the 60-year-old that Doug Lowy was mentioning here in the United States, we're talking in the around 40 years of age, a substantive male predominance. More than half of our liver cancers were chronic HBV infected. A smaller proportion had antibodies to HCV. And we had 18%, almost 1 in 5, that were infected with HIV. Of those with HIV, most of them had been previously diagnosed. Most of those had been on ART and had been doing well with viral suppression. So they had been in contact with the HIV care system prior to this diagnosis of hepatocellular carcinoma. We did a standardized assessment of a number of symptoms that might be present at diagnosis. And here I'm presenting both in the lighter shade, those who are HIV negative, and in the darker shade of coloration, the HIV positive cases. And whether you're looking at the symptoms or signs, first you notice that there's a triad of hepatomegaly, so abdominal pain, enlarged liver, and frequently weight loss really occurred in about 90% of liver cancer cases. And in fact, if you did the performance characteristics of that as a clinical case definition, it actually performs quite well in the absence of any ultrasound alpha fetoprotein or other sort of additional measures, unfortunately. But we don't see any differences in the clinical presentation by HIV status. The symptomatology, the physical findings were very similar, despite the presence of HIV. What we do see is very multifocal disease. So this does not prevent at early stages. The great majority have multifocal disease, often not just a couple of lesions, but multiple lesions, many times with the background cirrhosis also present. These are important because the likelihood for curative localized therapies, as well as potential resection, those are more limited in this population with advanced presentation. And unfortunately, this is the West African photograph from many years ago when I was working there, that a pregnant man delivers in his grave. And we did document among this large number of liver cancer cases with survival follow-up that the median survival was only 6 weeks, not 6 months, 6 weeks was the median survival, if you look right here. With such a rapid progression to mortality, it's actually difficult to distinguish factors that might accelerate this process. So HIV status really didn't have a dramatic difference. We did see some signal that those with more advanced immunosuppression with HIV, those in particular, those with CD4 less than 200, had a more rapid progression to mortality. But again, this is in the backdrop of largely uniformal and rapidly fatal disease. This is our main etiologic findings, in which, as would be expected, hepatitis B, and in this case, we had an over 20 odds ratio for being surface antigen positive in liver cancer risk, about a 4-fold increased risk with hepatitis C, both of those as would be expected. We did find, particularly in the ENT and dental clinics, significantly about 2.5-fold increased risk for liver cancer with HIV infection. And perhaps even more intriguing was the fact that a very high proportion of our liver cancer cases expressed urinary antigens for active infection with schistosomiasis and had a 4-fold higher risk. This was interesting to us. We also noted an interaction between schistosomiasis and liver cancer risk, with schisto exposure alone associated with about a 2 or 3-fold increased risk. Again, that 24-fold higher risk associated with chronic hepatitis B. And if you look at the joint exposure, it's approximating a multiplicative effect of the 2 individual exposures. We were concerned that this schisto association might simply represent confounding by where people were or being exposed to water or other things like that. But as you can see, the 4-fold increased risk was very consistent irrespective of region. We looked at other sort of water sources as well, with the lone group of being surface antigen positive being a more attenuated risk associated with schisto. And this, from an epidemiological perspective, when the risks are reduced, that suggests there could be a common pathway involved in both schisto and HBV, leading to increased risk. When we look at that data, interestingly, we see that, again, these 2 columns simply compare a variety of HBV markers in those with schisto in the first column versus those without schisto in the second column. So in terms of just exposure measured by anti-core positivity, we have a higher proportion of exposure among those with schisto there is more schisto in some of the regions of the country where hepatitis B also is known to have a higher burden. But then among those with core positivity, we find a notably higher rate of chronicity with 50 compared to 30% by schistostatus. And among those, we note the higher level of detectability as well as a tenfold higher level of HBV DNA among those with active schistosomiasis infection compared to those without. So this prompted us, well, in terms of take-home points from the case control study, we're able to recruit a pretty large number of cases within a few years, documented the rapid mortality. We note this interesting interactive effect of hepatitis B and schisto. There's a main effect of HIV that we also see with our, in particular with our more appropriate control group of the outpatients. And I didn't have time to go into aflatoxin. And in interest of time, I'm going to skip over that as well. We also wanted to look at our, sorry about that, we wanted to look at our HIV positive patient population. So at the Infectious Disease Institute in Kampala, we screened about 1,950 patients at baseline, again with a rigorous evaluation that include a non-invasively measuring fibrosis with FibroScan, rolled if they had significant fibrosis cirrhosis by FibroScan or had viral hepatitis markers that were rolled into long-term follow-up. And we have identified a handful of liver cancer cases through this study. As would be expected, we documented the male predominance as well as risk associated with chronic Hep B and HCV as being factors which contribute to fibrosis. In addition, in a summary of more detailed data, those who had not been on active ART were markedly higher risk. We saw this increasing dose response effect of longer durations of time on antiretroviral therapy being associated with a protective effect. Notably, for most of the history of ART regimens widely available in Uganda, there's been some level of HBV active medications incorporated as part of them. And for the great majority, they are now on a Truvada containing regimen with a couple of active HBV antivirals. We also found increased risk with HBV DNA, particularly at around 10,000, but our mutational analysis was not so compelling in terms of additional risk beyond viral load or other markers. So take-home points from this investigation was that we can recruit and follow HIV positives at risk for liver disease. Consistent with other data, there's a significant loss of surface antigen and protective effect of antiretroviral therapy among the co-infected individuals. There was some signal with our CD4 load with fibrosis. We also noted, and this has been replicated in other studies around Uganda, that 40 to 50% of individuals are neither vaccinated to be protected, nor have they been exposed as a child. So a substantial proportion are susceptible to hepatitis B. Additionally, in another setting, we've documented that it's actually been hepatitis B and among the adults in Uganda are actually at risk in relation to, so both HIV and the number of sexual partners is a risk factor for chronic hepatitis B. So the nature of the modality of transmission for hepatitis B in Uganda is changing from what was purported to be predominantly childhood transmission, and you likely were exposed and protected for life, even among those who have not yet been, among the cohort older than vaccination, there's a substantial number that remain susceptible. And we also were able to operationalize liver cancer screening with 6-month visits. But again, the incidence is relatively low, even among a higher risk cohort. So our take-home point, again, myself as an HIV viral hepatitis epidemiologist, is that we have infectious diseases that can be treated with a possibility of prevention or cancer interception strategies. So we have a variety of different modalities. And additionally, for evaluation of these approaches, we have, in most cases, measurable and reversible endpoints that can be looked at without waiting until clinical diagnosis of liver cancer might be made. With this and with the call for funding for additional renewals or expansions of these program project grants, we formed with our partners in Senegal, particularly led by Moussa Seydi and Gilles Wandeler, who have been doing very comparable work to what we were doing in Uganda. We evolved from the H2U to the H2A consortium with representation then from both East and West Africa. And our goals with this next 5 years of funding have really been to develop a broader cohort looking at the natural history of chronic hepatitis B, screening for liver cancer with the biorepository, looking at potential biomarkers, as well as much more detailed mechanistic investigation into this interaction between hepatitis B and schisto. There's the broad aims. Again, my apologies for going a bit fast, but I'm trying to make up some time. So I just want to mention some of the barriers to liver cancer control in Africa. And this is really sort of from my viewpoint and in discussions with my colleagues, largely from Uganda. Vaccination uptake in Uganda, probably a 70 to 80% compliance or adherence to childhood vaccination, but that doesn't include the birth dose for those that might be at much higher risk. Birth dose in most of sub-Saharan Africa is largely not readily available. Part of that is because antenatal and adult screening for HPV is also largely not available. Even among most HIV clinics in sub-Saharan Africa, hepatitis B surface antigen is not routinely tested. There's been a difficulty in trying to get tenofovir or those non-ART, Truvada as part of ART is much more widely available than is tenofovir. We need better screening strategies. As is mentioned, it's a very dismal diagnosis. We need to advance and find a way to identify people at earlier diagnosis. Whether it's through biomarkers, as Jill was discussing, or other approaches, including liquid biopsy that Doan mentioned, we really need better markers of higher risk. If we are able to identify earlier diagnosis, we need to make sure that we have curative treatments available. We tried to provide support for interventional radiology to do localized curative therapy in Uganda. It's been a real struggle. In a population of 45 million in the country, there's never more than 2 to 5 individuals who might be able to perform these interventional radiology approaches for potential cure of those who might be diagnosed earlier. We're pleased to say there's been about 5 liver resections for early HCC, perhaps some that were more palliative in nature, but we've never had a liver cancer surgeon until recent years able to perform any type of liver surgery. We recognize that there's going to be a substantial number of persons who are going to be diagnosed at advanced stages, and we have little to offer them. And even if better pain control and a more holistic palliative care approach could be improved, that would really be important for management of liver cancer in this setting. Finally, all of these barriers happened in the presence of an overburdened healthcare system that struggles to take care of routine issues, much less consider prevention and control of cancer. So my colleagues, and hopefully we have some time for Professor Ochama to weigh in after my talk, they've really taken the lead in working towards leveraging the HIV care model, as well as the existing infrastructure for liver cancer control in Uganda. Ponciano has launched a project recently where he's going to screen up to 37,000 pregnant women at different referral hospitals in the country to try to deliver both the birth dose as well as antivirals to mom and baby as appropriate. We recognize that adult vaccination with 50% or more of the population at risk, we need to integrate approaches for I'm not sure why this is advancing. We need to integrate approaches for adult vaccination. In a study led by Uni Manana among high-risk female sex workers, we note that there was a pretty reasonable completion of the 3-dose, but a very high completion of 2 doses has raised us to consider some of the new alternative vaccination schedules, as well as some of the novel hepatitis B vaccines that might be appropriate, particularly for high-risk populations. Drs. Ochama and Joan Mutoba from the School of Public Health at Macquarie University have done a lot of work in integrating HBV diagnosis and treatment into routine HIV care, training the providers, demonstrated cost efficiencies, but there's a significant loss to follow-up. And that's led to them also now recently launching peer support for improving engagement in HBV care. All of these things, whether it's PMTCT, that model has been very well advanced in the setting of HIV infection. Treatment and engagement in care, making sure that people continue to come back and engage in care and take their medications. That's certainly been, all of these are HIV care model issues that we've struggled over the last couple of years. I did my doctoral dissertation 20 years ago, just before the rollout of ARTs was available. And there was a clear skepticism that that could be achieved. I think in many cases, there's been skepticism that we can aggressively and widespread treat hepatitis B, identify and diagnose those that need treatment, and hopefully care for those who are eventually diagnosed, preferably at earlier stages. But I go back to the skepticism that existed before PEPFAR, before 20 million persons are on antiretroviral care across sub-Saharan Africa and growing each year. So I think we need to take lessons from HIV care delivery model, leverage the infrastructure, and hopefully that will be of benefit as we try to eliminate hepatitis and liver cancer in Africa. In conclusion, I think we know a lot about the etiology. We have a lot of recognition about hepatitis B and C. I think the next phase in terms of etiology is really about exploring these co-infections and cofactors, as mentioned, both cysto as well as aflatoxin and hepatitis delta. We're working as well on liquid biopsy and other biomarkers, which might identify individuals at greater risk for liver cancer, so we could target screening efforts more appropriately. We still have a lot of work to go in terms of making sure that efficacious curative treatments are identified as well as made widely available. But we have a lot of things in our toolbox, vaccine and antivirals in particular. We have a great model and infrastructure to expand in the terms of the HIV care model. And I think what we really need to be leveraging and working towards is to develop the resources, the mobilization of community and individuals around particularly sub-Saharan African countries to also support these efforts for diagnosis, management, and treatment of hepatitis and liver cancer in these settings. And with that, I want to acknowledge the long-term partnership with Ponciano, a professor at Macquarie University in Uganda. I want to also recognize the growing work with our Senegalese colleagues, Moussa Seydi and Gilles Wandeler, who've been working there for a long time. Without going into details, it's a partnership of many different investigators from Uganda, Senegal, as well as at Hopkins. I want to thank Geraldina for her advocacy for amongst NCI and broader amongst the NCI malignancies group to make sure that liver cancer is not a forgotten malignancy amongst those HIV-associated cancers. And then finally, to thank our large and productive staff and the willingness of the participants to work with us. And with that relatively rapid approach, I think we might have made up a little bit of time, and happy to take some questions now, or if you want to give Dr. Ochama a chance, whatever is your preference.
Thank you very much, Dr. Kirk. I just want to maybe one question, and then I will pass it back to Dr. Ward. one question here is that have you looked into using FIB4 or APRI scores to assess fibrosis, given the limited access to FibroScan?
Yes, we have looked at some of those, and they perform pretty well. And I think actually, in terms of both looking at people who have fibrosis in the absence of the availability of biopsy defined or even non-invasive FibroScan, those certainly are approaches. They have their limitations, and some of them can be, but some of those could be integrated, and they are being integrated into approaches for defining treatment need for HBV antiviral therapy. They're not great, they're not perfect, but they're helpful.
Thank you.